Right. So as a part of this microsystem, the implementation science laboratory, yeah. Joe, can we have the first question?
I guess I have two questions. One, the main one is for David with regard to the accreditation. One of the things that was notably absent from these 27 things and 17 things is any mention at all of palliative care services as a referral. I would contend that with mortality to incidence ratios of 0.2 to 0.3 in the U.S. and 0.7 overseas, that's considerably more important issue than genetic counseling, let's say.
I didn't have time to really drill down in great detail, but palliative care, in fact, is one of the components under rehab and support systems. There are several there, but certainly palliative care is highly regarded, highly important in our program, and is recognized.
Yeah, please. Dr. Donnelly.
I had two comments to make. Our first and third speakers both mentioned the need for baseline data, and I just thought that I could possibly make a very specific, focused reflection on what we should consider to be baseline data in the context of the places we've been discussing in the last couple of days. And that is, it seems to me that the data that we need in terms of breast cancer can be kept relatively simple. It doesn't have to be simple, but it can be simple, and that can just be population served by the individual's unit, incidence, and stage at presentation. To say, it doesn't have to be complicated, but we just have to know that it's complete and sound. I wonder if that's something that, as a group, we should continue to emphasise and push for. The other thing that I just wanted to mention in the context of the second presentation was just a few comments on the UK approach to multidisciplinary teams and quality assurance. In the UK, in the 1990s, there was an awful lot of publicity about disparities in breast cancer treatment offered around the country, and it became a real political hot potato, with the result that now in the UK, every unit that offers breast cancer care has to show evidence that it is meeting very rigorous guidelines on every aspect of the care that's delivered, and that's both for screening service and for a symptomatic service. And the huge advantage of this is that if your service is failing in some way, although that's very painful to acknowledge there are deficiencies in your service, nevertheless that gives you the power and the impetus that you need to get resources to improve those areas in which your service is failing. So although we moan about it, that being something that actually keeps us pretty happy in the UK, being able to moan fairly constantly, but although it's time consuming, we moan about it, it's difficult, and as I say, we find it particularly difficult to acknowledge deficiencies in our service, it does give us the power to introduce improvements.
In the same line, David, if I may ask, as an aftermath of accreditation process, have there been any assessments to see whether the outcomes in the form of either survival in the regions where accreditation has occurred versus the regions where there is no accreditation, or quality outcomes like, say, maybe conservations, number of conservations, the number of reconstructions, whether these have improved in these regions in any way?
That's the ultimate goal here, is to demonstrate improvement in a variety of outcomes, and the program isn't old enough to get into, for example, 5-year specific breast cancer mortality, although it's one of the metrics we're going to look at. We have measured the 3NQF measure compliance with those radiation therapy, adjuvant chemo, and hormonal therapy, and that has been tracked for the past 3 years and has gone from roughly 60% compliance across the board in the United States to 80 to 90%.
Well, those kinds of numbers need to be brought into public domain for individuals to come forward this accreditation process. The other part is that is there some additional cost that is incurred due to the process of accreditation? And if that is documented, then some kind of cost-effective analysis that because of this much of cost being added, this is the gain.
Yeah, there's a survey fee that is $3,000, $4,000 actually now for every 3 years that the center pays to the NAPBC to cover the costs of survey and maintenance of the program. As I said, most of these programs we've accredited have most of these standards and components in place. Not all of them fully developed, though, like patient navigation. So I can cite experience from our own center where our patient navigation system was less than ideal. It was good, but less than ideal, and the administration recognized the standard that needed to be met for accreditation, and they hired some more nurse navigators, trained nurse navigators.
Perfect. Yeah. Yeah, please go ahead.
Thank you very much. My first question goes to Dr. Porter. The whole issue of implementation science, in my view, has got to do with the no-do gap, what we know and what the science is telling us and what we're actually doing on the ground. And I was wondering if you have an example of what we know and what we are doing to speak to that. And my second question goes to Dr. Thompson on your very good research that you did on using qualitative research methods. But I was wondering if you can speak a little bit about how you were able to ensure intercoder reliability, because you said the teams were independently coded by the staff, and then what ethnographic or epistemological perspective actually informed your study. Thank you.
I'm not exactly sure what your question is, but I think in terms of giving an example, maybe going a little more into the example that I did give, and saying that we have some information about decreasing mortality in the United States, but that doesn't necessarily cover all populations. Part of that is, if you notice the mortality to incidence ratio that I gave you for North America, it was 0.19. And when you look at the ratio for whites in the United States, it's 0.19. So what we know is that whites are primarily driving that number, and that that in any country, in any population that's varied, you really have to have deep data to understand how to do things at a local level or within populations that have cultural differences or economic differences. And so I think that's an important piece of this, in having the data. Then when you look to see what you think your outcomes might be, you really need to integrate as much information as you can. And I agree very much with the comment that these data don't have to be complicated. They don't have to be at a high research level. They need to be at some level so that you're at least thinking about the data that you're trying to, you're thinking about your next step. And when you think about your next step, what do you need at even a rudimentary level within the population that you're looking at over its variations to go to that next step? And so I think having that intent, having the knowledge of where you're going, and then getting the amount of data that you need, that you can get in some way with the resources that you have to go to that next step. And so